Hello, and thank you for joining me. I'm Zach Fulkerson, and I direct the Pulmonary Hypertension program at Indiana University. I want to try something a little different with you today. Pulmonary hypertension has a history, a long one, and most of us learned it as a pile of disconnected facts, a definition here, a trial acronym there, a drug name we memorized for boards and never thought about again. But there's a better way to hold all of it in your head. Think of it as a certain pop star thinks about her career. A series of eras, each one with its own sound, its own look, and its own preoccupations. Each one building on the last one. So today, we're going to do the eras tour of pulmonary hypertension, from its silent origins on the autopsy table all the way to the molecular medicine we're writing prescriptions for in 2026. My promise to you, by the end of the trials and the drugs won't be a list anymore. There'll be a story that you can tell. Quickly, my disclosures. I have no relevant financial relationships to disclose. One disclosure that is relevant to what you are about to see, I used artificial intelligence to generate many of the illustrations and graphics in this deck. The medical and scientific content, the interpretation, the clinical judgment, that's all mine. But the artwork that's going to carry us all the way through the eras was synthesized with AI, and I think you deserve to know that up front. And these are the eras. The first, the morbid anatomy era. This is the era of the diagnostic void. Picture the toolkit of a modern physician, and then take it all away. No echocardiogram, no right heart cath, no biomarkers, none of it exists yet. Which means pulmonary hypertension in this era is something that a clinician does not diagnose. It's something a pathologist finds. It's a disease defined by what's seen under the glass, after the fact. Hold on to that idea. A disease of the pathologist, not the clinician. Because everything that follows is the story of us slowly wrestling it away from the morgue and into the clinic. The year is 1891 and the place is Leipzig. A 24-year-old woman comes in. Breathless, exhausted, drowsy all the time. There's a bluish cast to her skin. The veins in her neck are distended. Over time, she develops chest pain, lightheadedness, episodes of fainting, and not long after, she dies. And, as it was the custom of her era, her body is taken down to the basement. The autopsy is performed by Ernst von Romberg, and Romberg is meticulous. He looks at the heart and finds the right ventricle is massively hypertrophied. A chamber whose walls should be thin and compliant, now thickened, overbuilt, and ultimately failed. But here's the detail that makes him a careful scientist. The valves are pristine. There's no mitral disease. There's no congenital heart defect. Nothing to blame upstream. What he finds instead are pulmonary arteries that are thickened and damaged. The problem, for the first time, is being localized to the lung circulation itself. Romberg needed a name for what he saw, and the name that he reached for was pulmonary vascular sclerosis, a hardening, a scarring of the pulmonary vessels. It's worth pausing on that word choice. He didn't describe a pressure or flow. He described a texture, a structural disease of the vessel wall itself. And as we'll see at the very end of our tour, that 19th century instinct, that this is fundamentally a disease of remodeled tissue, it turns out to be exactly right. So what is actually happening in those vessels? This is the histology. And the vocabulary here is worth owning because these are the lesions that define the disease to this day. You get medial hypertrophy, smooth muscle hyperplasia that extends further distally into the vessels than it ever should. You get intimal thickening, concentric and laminar. It's what's called plexogenic, but also eccentric and non-laminar forms exist. There's adventitial proliferation, the outer layer thickening, studded with perivascular inflammatory infiltrates. There are plexiform lesions, these complex and disorganized proliferative channels with focal disruption of the media, the pathognomonic fingerprint of advanced disease, and finally, in situ thrombosis, clot forming right there in the vessel because the endothelium has lost its integrity. 5 lesions. Hold them in mind because in a few decades a diet pill is going to reproduce this exact picture, and much later a drug is going to try to undo it. Pulmonary vascular sclerosis, a disease of the pathologist, is where we are. In this period, pulmonary hypertension isn't even really a thing. Well, not as we recognize it. It's sclerosis. It's pathology. Not yet physiology. The diagnosis is an endpoint, the last entry in the medical chart. It's not a starting point for care. And that is how things would stay for roughly the next 50 years until someone did something genuinely unhinged. The year is 1929, and this is where pathology starts to become physiology. A German surgical resident named Werner Forssmann becomes convinced you could pass a urological catheter into the living human heart. His superiors forbid it, so he does what any reasonable resident does. He experiments on himself. He anesthetizes his own arm, cuts down, and threads a urological catheter up his vein into his own right atrium. And then, catheter still in his heart, he walks himself down to the radiology suite and gets a chest film to prove it reached the right atrium. And that's the image. For his trouble, Forssmann was fired. The idea sat untouched for about 12 years before anyone had the nerve to pick up the baton. That baton was picked up in 1941 by two physicians, André Cournand and Dickinson Richards, who refined Forssmann's stunt into a science. They built on the foundation of pulmonary hemodynamics, the normal values we still quote. In 1956, the three of them, Cournand, Richardson, and Forssmann, shared the Nobel Prize for the right heart catheterization. And Forssmann, by then, he'd become a urologist. Their framework gave us the numbers on this table. Your normal mean PA pressure in the low teens to 20, a wedge of 4 to 12, a cardiac output of 4 to 6 liters per minute, and it gave us a way to think. Paul Wood likened pulmonary vascular resistance to Ohm's law, pressure equals flow times resistance, which is why to this day we measure PVR in Wood units named for him. That mental model, mean PA pressure equals cardiac output times resistance plus the wedge pressure, is going to come roaring back when we talk about why pressure alone can fool you. And around this time, in the same spirit of finally naming the thing, David Dresdale coins the term primary pulmonary hypertension for the very first time. So let's wrap up this era. We've made real progress. Pulmonary hypertension is no longer just a finding in the basement. It's a disease we can identify in a living, breathing person with a needle and a pressure transducer. But, and this is big, there's still nothing we can offer them. There's no treatment. The condition remains mysterious, tragic, and as far as anyone can tell, rare. But that sense of rarity is about to be shattered. By the 1960s, things change, and they change suddenly. This isn't a slow scientific evolution, it's an outbreak, and the culprit, it turns out, is sitting in the medicine cabinets all across Europe. Put yourself in the shoes of a physician at a major referral hospital, say Bern, Switzerland in this period of time. In a normal year, you might see a couple cases of severe pulmonary hypertension. It's rare enough that when one comes in, you make a point of bringing your students around to see it because they might not encounter another case for a very long time. But in the same week, another case walks in, a patient with the same picture, same symptoms, and then another, and another, and another. It's no longer rare, it's an outbreak. Patient after patient, severe shortness of breath, fatigue, chest pain, syncope, all of them showing the signs of right heart failure. At that hospital in Bern, the incidence climbs 20-fold. Now this is where it gets good, because this is detective work. Epidemiologists, among them Dr. Hans-Peter Gertner, start canvassing these patients looking for the common thread, and they find it. 76% of them were taking the same over-the-counter diet pill, a drug called Aminerex. So what is Aminerex? Structurally and functionally, it's a cousin of amphetamines, and it was available over-the-counter as an appetite suppressant. It causes significant vasoconstriction, and in susceptible people, it triggers genuine structural remodeling of the pulmonary vessels. And remember those 5 lesions from Romberg's era? Aminerex reproduced them. The medial hypertrophy, the plexiform lesions, the whole picture. And here's the haunting part of it. It only happened in maybe 1 or 2% of the people who took it, which is exactly what made a toxic trigger so hard to catch. Most people are fine, so the signal hides in the noise. And if the story sounds familiar, it should. The United States got its own sequel in the 1990s with the fen-phen epidemic. Fenfluramine right there on the slide. Same family, same tragedy. To everyone's credit, the response was fast. Aminorx was introduced in 1965 and pulled from the market in 1968, just 3 years later. And within a few years, the incidence of pulmonary hypertension fell right back to baseline. The epidemiology proved the cause. But a scare like that leaves a mark. It prompted the field to convene, and in 1973 we get the very first World Health Organization Symposium on Pulmonary Hypertension. That first symposium did something quite revolutionary. It gave us a common language. For the first time, people studying the disease around the world agreed on definitions, and those definitions were grounded in normative data. The data showed that a mean PA pressure sits in the mid-teens and only rarely climbs above 20. So the group landed on a mean PA pressure of 25 millimeters of mercury or greater as a pragmatic consensus cutoff for the disease. I want you to hold on to that number, 25, because that threshold is going to stand essentially unchallenged for nearly half a century. And then, near the end of our tour, we're going to tear it down. The symposium also recognized that pulmonary hypertension isn't one disease, it comes in different flavors. The earliest groupings were crude, but they evolved into the modern World Health Organization classification we use every day. Group 1, pulmonary arterial hypertension. Group 2, due to left heart disease. Group 3, due to lung disease and hypoxemia. Group 4, chronic thromboembolic disease, and Group 5, the unclear and multifactorial bucket. Most of what we talk about today lives in Group 1, but the discipline of always asking which group starts right here. With a shared language in place, the field could finally do something it had never been able to do: study these patients systematically. So in 1981, the NIH registry is proposed, and it begins collecting data between 1983 and 1987. And the registry marks the close of the toxic trigger era and opens the beginning of the next chapter, the era in which we finally find out with hard numbers just how dangerous this disease really is. The NIH registry results are published in 1987, and for the first time, we have a portrait of who this disease strikes. The average patient is young, around 36 years old. It favors women, approximately 1.7 to 1. There's a punishing average delay of about 2 years from the first symptom to diagnosis. 2 years of being told it's asthma or anxiety or deconditioning, and by the time they're diagnosed, the hemodynamics are already advanced. A mean PA pressure averaging around 60, elevated right atrial pressures, depressed cardiac index, and a reduced diffusing capacity. These are not early patients. These are patients who've been sick, undiagnosed, for a long time. And then in 1991 comes the number that defined the era, their survival data. Median survival from the diagnosis, 2.8 years. Sit with that. It is 1991, a full century after Romberg's young patient in Leipzig, and the outlook for this disease is, frankly, almost as grim as it was in 1891. We can name it, we can measure it, we can classify it, and we still cannot meaningfully change its course. It wasn't for lack of trying. This era has a graveyard of failed therapies: hydralazine, captopril, isoproterenol, drug after drug tried and found wanting. There's one important asterisk, and it still matters in your clinic today: the calcium channel blockers. About 10% of patients, and only about 10% of patients, are true vasodilator responders. And in those select patients, calcium channel blockers can do real good, but on the other 90%, they're just not effective. They're also dangerous, capable of precipitating hypotension, RV collapse, which is exactly why we still do acute vasoreactivity testing before we ever reach for them. And then there was a glimmer. In the lab, prostacyclin, PGI-2, it clearly worked. The problem was, it only seemed usable for a short-term tool. Turning that glimmer into a therapy is the whole story of the next era. So we cross out of the natural history era and into the ice pack era, the era of our very first drug, and we call it the ice pack era for a reason that's going to become painfully clear in just a moment. This is it, epoprostenol, intravenous prostacyclin. The pivotal trial reads out in the mid-1990s, and look at the separation of those curves. At 12 weeks, 20% mortality in the placebo group, and 0% mortality in the epoprostenol group. Compared to conventional therapy, epoprostenol improved 6-minute walk distance, improved hemodynamics, improved symptoms, and most importantly, it improved survival. For decades, epoprostenol was the only PAH therapy with a proven mortality benefit from a randomized trial. After 100 years, we finally had a drug that didn't just make people feel better, it kept them alive. More than 100 years after Romberg's first patient, the field finally had something to offer. You can imagine the relief: improved survival, improved hemodynamics, improved functional status. So now, picture yourself as a physician in 1995 or 96. You sit down with your patient and you tell her about this new drug, the first thing in a century that can actually extend her life, and she looks at you and says what any one of us would say: that sounds amazing, but what are the downsides? And this is where you sigh, because the downsides are formidable. Epoprostenol has to be given as a continuous intravenous infusion, which means a permanent central line with everything that implies: infection risk, thrombosis risk, line complications. The drug isn't even thermostable, so it has to be kept cold. Patients literally had to carry ice packs to keep their medication from degrading. That's the era's name, and it's not a metaphor. And the half-life? About 6 minutes. 6 minutes. Which means if the pump fails, or the line kinks, or your toddler pulled the line out altogether, the rebound pulmonary hypertension can be immediate and life-threatening. There are side effects: the classic first bite jaw pain, headache, nausea, and flushing. And then there's the sheer relentlessness of it: showering with your line wrapped in plastic, mixing your own medication, tethered to a pump 24 hours a day, every day, for the rest of your life. So yes, the ice pack era was full of burden, but make no mistake, it was a start. It was proof that the disease could be beaten back. The job for the next era was to keep the benefit and lose the ice pack. But before we get going with the next reps, I want to stop the tour for a few minutes, because to understand why these therapies help, you have to understand why these patients can't breathe in the first place. Quick detour. Bear with me. It's the engine room, and it pays off. Let's start with the simplest model possible. The body is an engine and exercise is combustion. Fuel plus oxygen yields work, plus carbon dioxide is exhaust. Whether you're burning fat or carbohydrate, the equation balances. You bring oxygen in and you put out carbon dioxide. Hold that frame. Oxygen in, CO2 out. Because pulmonary hypertension breaks both halves of the equation. The cardiopulmonary system exists to do exactly this: deliver oxygen to the muscle while clearing the CO2 waste. Think of it like a car. The engine demands fuel and air, and it has to vent its exhaust. If either the fuel delivery or the exhaust system fails, the engine sputters. In pulmonary hypertension, both fail, and here's how. Start with delivery. By the Fick principle, oxygen uptake depends on cardiac output. And here's the deceptive part: if you only look at oxygen consumption, VO2, early in exercise, the PH patient looks almost identical to a healthy person. They track right along the normal line. They just quit much sooner. The VO2 graph alone won't tell you why. The why shows up in late exercise, because the failing right heart can't raise cardiac output. Oxygen delivery falls short of demand, and it happens earlier than it would in a healthy patient. So the muscle switches to anaerobic metabolism, generating lactate. That lactic acid gets buffered by bicarbonate, the body's most immediately available buffer, and that buffering reaction generates an additional load of CO2 on top of the normal exhaust. So now we have a CO2 problem. Watch what happens to CO2 production. In the pulmonary hypertension patient, VCO2, or CO2 production, spikes earlier in exercise. At a given workload, they're generating far more CO2 than a healthy person. Look here. The CO2 output of our PH patient produces at 100 watt is what a healthy person doesn't hit until 150 watts. And here's why that matters so much. CO2 is a far more powerful driver of ventilation than oxygen is. So this is a surge of CO2 that translates directly into air hunger. And then comes the second failure: ventilatory inefficiency. To clear all that CO2, an alveolus has to be perfused. Blood has to reach it. But in pulmonary hypertension, blood flow to large portions of the lung is choked off. So you're moving air into and out of alveoli that had no blood flow to them. The ventilation is wasted. It's dead space. We quantify this with the VE to VCO2 slope, essentially how much air you have to move to clear a given amount of carbon dioxide. In pulmonary hypertension, that slope is steep. The patient has to breathe more and more and more just to clear the same amount of CO2. They are working their tail off and getting very little in return. Now put those two failures together. Here we've got CO2 production against work rate, and we've got minute ventilation against CO2 production. But let's put those two together, and you get something like this. You have a pulmonary hypertension patient breathing the same minute ventilation at 100 watts as a healthy person would at 250 watts. So basically, they are breathing the same as someone who's doing over 2.5 times the workload. You've got a flood of extra CO2 pouring out of early anaerobic metabolism, and it slams straight into the wall of ventilatory inefficiency. Too much exhaust and a broken exhaust system. The result is profound dyspnea and exercise intolerance. And this is the elegant part. This is why epoprostenol worked on more than one front. By improving pulmonary blood flow, it reduced the dead space and improved ventilatory efficiency. And by improving cardiac output, it delayed that anaerobic threshold, pushing back the moment that CO2 begins to flood in. One drug, both failures. Detour's over, let's get back on the road. And get rid of that ice pack. The 2000s opened the tablet era, and the entire ambition of this era can be summed up in one sentence. There had to be something better than a pump and a bag of ice. There had to be a pill. And the first wave of pills arrived right at the turn of the millennium. 2 landmark trials, 2 brand new pathways, both oral. The first is Breathe 1, in 2001, testing bosentan. This is the first endothelin receptor antagonist, our first ERA. The endothelin pathway is one of the great vasoconstriction and proliferative drivers in this disease, and bosentan blocks it. The headline result, a roughly 54-meter improvement in 6-minute walk distance at a high dose, with better functional class and dyspnea scores. The price of admission was hepatotoxicity. Dose-dependent, reversible, but it meant monthly liver function testing, and teratogenicity, which makes pregnancy prevention non-negotiable. But the point stands. For the first time, meaningful PAH therapy came in a pill. The second trial is Super 1, reading out in 2005, and it opens an entirely different pathway, the nitric oxide or cyclic GMP pathway with sildenafil, a phosphodiesterase 5 or PDE5 inhibitor. The same molecule you know from another indication, working here by preserving cyclic GMP and promoting pulmonary vasodilator. Super 1 showed improvement in 6-minute walk tests across all doses, plus meaningful reductions in mean PA pressure and PVR, and it was safe and well tolerated. So now in the span of a few years, we've gone from one brutal intravenous drug to oral agents hitting 2 distinct pathways. And that's the conceptual backbone of everything that follows, so let's make it explicit. There are 3 pathways we can target in PAH. The prostacyclin pathway, that's epoprostenol and its descendants. The endothelin pathway, the ERAs like bosentan, and the nitric oxide and cyclic GMP pathway, the PDE5 inhibitors, and soon the soluble guanylate cyclase stimulators. 3 pathways. Every drug we're about to meet plugs into one of these 3 sockets. If you hold on to this picture, the rest of the tablet era organizes itself. There's one more thread from this period that I want to plant now and harvest a bit later. In 2000, researchers identified a genetic cause of heritable PAH, mutations in BMPR2, a receptor in the bone morphogenetic protein signaling family. Why flag it now? Because BMPR2 normally restrains cell growth in the vessel wall. Lose it, and you tip the balance towards proliferation, toward Romberg's sclerosis. File that away. In the molecular era that's coming up, we're going to come right back to this exact same picture of balance and a drug designed to work around it. So with our 3 pathways in hand, prostacyclin, endothelin, nitric oxide, let's actually build the toolkit drug by drug. I'm going to walk you through how this medicine cabinet filled up over about 15 years. Watch the 3 columns fill in. We start with where we have been before with the OG, epoprostenol 1996, the prostacyclin pathway. Its advantage is singular and for decades was unmatched. For a long time, it was the only PAH medication that was shown in a randomized study to reduce mortality. Its disadvantage you already know intimately from the ice pack era: the stability, the 6-minute half-life, the central line, the relentless burden. It was the best drug we had for a long time, but also the hardest to live with. Next was our new class, bosentan, the endothelin receptor antagonist that we saw from the Breathe 1 trial. The advantage that changed everything: it is oral. The catch: significant hepatotoxicity, around 10%, with mandatory monthly liver monitoring, plus teratogenicity. Next is back to our prostacyclin pathway, but smarter, treprostinil, around 2002. The new factor here is chemistry. Where epoprostenol has a 6-minute half-life, treprostinol's is about 4 hours, which gives you an enormous margin of safety if a pump ever fails. It's far more stable at room temperature, and it comes in multiple routes. It was originally subcutaneous and then IV, but later on inhaled and oral. The downside of the subcutaneous form is very real: infusion site pain. It's severe and seen in something like 85% of patients. Then we have Iloprost, 2002, the first inhaled prostacyclin. The beauty of it delivers that ice pack mechanism directly to the lungs, sidestepping the systemic side effects and, crucially, the central line. The cost is the burden of frequency: 6 to 9 inhalations a day, plus cough and throat irritation. It's hard to build a life around, and you'll note that it's no longer commercially available, but conceptually it proved you could nebulize this pathway. Now, the nitric oxide column opens with sildenafil, the Super 1 trial from 2005. The pitch here is simple and powerful. It's safe and it's oral, well tolerated, easy to start. This is the drug that made the nitric oxide pathway a routine, low-drama part of our regimen. Of course, this trial only looked at increased 6-minute walk tests. Back to the endothelin column with ambrisentan, the Ares 1 and Ares 2 trials from 2008. The refinement here is selectivity. It is a selective endothelin A antagonist and only once a day, with a much lower risk of liver toxicity than bosentan. So no mandatory monthly LFTs. The trade-offs are peripheral edema, which can be prominent, and nasal congestion, and teratogenicity remains a class effect. Then, tadalafil, the first trial of 2009. It's a long-acting PDE5 inhibitor, and its gift is convenience. Once daily dosing, a big drop in pill burden compared to thrice daily sildenafil. Of course, the flip side of a long half-life is that the side effects, myalgia, back pain, and the nitrate contraindication linger longer as well. Now, something genuinely different on the nitric oxide pathway. Riociguat, the Patent 1 trial 2013. It's the first soluble guanylate cyclase stimulator. Instead of preventing the breakdown of cyclic GMP like a PDE5 inhibitor does, it actually drives its production. So it works even when endogenous nitric oxide is low. That also makes it useful for patients who failed a PDE5 inhibitor, and it's approved for group 4 pulmonary hypertension as well, so chronic thromboembolic disease. 2 warnings worth burning in. It requires a careful blood pressure guided TID titration with real risk of hypotension and syncope, and it is absolutely contraindicated in combination with PDE5 inhibitors. Riociguat plus sildenafil or tadalafil is a dangerous combination. Don't do it. Back to the ERAs with macitentan, the Seraphin trial, 2013. And this one is a milestone for a reason that goes beyond the molecule. Yes, it has better tissue penetration, less hepatotoxicity than bosentan, but Seraphin was the first PAH trial since the original epoprostenol trial to be powered for and demonstrate benefit on morbidity and mortality endpoint, not just how far someone could walk in 6 minutes. We were looking at whether they stayed out of the hospital and stayed alive. That is a fundamental shift in what we demanded from our drugs. Its disadvantages are the same as the others in this class, which include edema as well as teratogenicity. And our toolkit's last major addition for now, selexipag, the Griffin trial from 2015. This is the one we'd been waiting 15 years for, the first oral non-prostanoid prostacyclin receptor agonist. It finally brought the prostacyclin pathway, the pathway that started in an ice pack, into a pill bottle for long-term maintenance, and it lowered disease progression and hospitalization. The catch is that you get the prostacyclin side effects, jaw pain, headache, diarrhea, without the raw potency of IV therapy, and it takes a patient lengthy titration to find the highest tolerated dose. It is worth noting that now we have two oral options, both selexipag as well as oral treprostinil. And there it is, the complete medicine cabinet. 3 pathways, roughly a dozen agents. In the span of one tablet era, we went from a single intravenous drug to a rich, mostly oral pharmacopoeia hitting every mechanism we ever understood. The drugs and the pathways are all right there for your reference in the future. So let's recap the era. We evolved from complex pumps to once daily tablets, an enormous quality of life victory, but there's a trade-off worth naming honestly. Pills are easier, but they often lack the hemodynamic punch of parenteral therapy for our sickest patients. We have filled the 3-pathway toolkit, which set up the next questions entirely. We now have approximately a dozen drugs. The question is now which one or which ones to pick. And our goals were shifting underneath us too, from how far can you walk today to how do I keep you out of the hospital alive for the next 5 years. That question, how to use an embarrassment of riches, is the whole next era. Welcome to the polypharmacy era. We have the tools. Now how do we use them? This is the great paradigm shift of the era. The question moves from what drug do I use to how do I optimize this patient? From reactive to proactive, from chasing symptoms to targeting survival and risk reduction. To do that well, we had to rethink 3 things: how we define the disease, how we measure severity, and how aggressively start treatment. Start with the definition. Remember that number 25, the consensus cutoff from 1973? After about 45 years, we finally changed it. The modern hemodynamic definition of PAH is a mean PA pressure greater than 20, a PVR of 3 Wood units or more, and a wedge pressure of 15 millimeters of mercury or less. Why move the line after nearly half a century? 3 reasons. First, true normal is lower than we'd been pretending. The actual normal mean PA pressure is about 14 plus or minus 3. Second, the data showed that even borderline patients in that old 21 to 24 millimeter mercury gray zone carry increased mortality. They were never truly normal, we just weren't calling it. And third, early intervention. If you can identify the disease earlier, you can treat it before the remodeling becomes irreversible. The new threshold is really a statement of philosophy. Catch it sooner. But here's the concept I most want you to leave with from this era because it's the most common way smart clinicians get fooled. Pressure is not the same as severity. In late-stage disease, mean PA pressure is actually a poor marker of how sick someone is. Go back to Paul Wood and Ohm's law. Mean PA pressure equals cardiac output times resistance plus the wedge. Now watch it evolve in 3 stages. Stage 1, resistance rises, but the right ventricle compensates and keeps cardiac output up. Because the mean PA pressure is the product of these two, the mean PA pressure also climbs. It looks bad and it's getting worse. Stage 2, the resistance keeps rising, but now the RV is starting to fail and output begins to drop. So the pressure here plateaus. Stage 3, the RV fails so badly that cardiac output craters. And because pressure is the product of output and resistance, the mean PA pressure actually falls. Think about how dangerous that is. A falling PA pressure can look like improvement when it's actually the sign of a dying right ventricle. So the takeaway, a moderate PA pressure with a low cardiac output is far more ominous than a high pressure with preserved output. Always read the pressure and the output together. Which is exactly why in this era we stopped staring at a single pressure and started stratifying risk across many dimensions. The framework is the 3-strata model: low, intermediate, and high risk, anchored to estimated 1-year mortality. We pulled from several domains at once: clinical signs of the right heart failure and functional class, exercise, either a 6-minute walk test or a CPET, the CPET including a peak VO2 and a VE to VCO2 slope, which we discussed earlier, biomarkers such as BNP or NT-proBNP, and imaging and hemodynamics, right atrial pressure, cardiac index, the echo findings. And the target is explicit and ambitious. Get the patient to a low-risk status. Get them to the green zone, a 1-year mortality under 5%. That's the goalpost everything else serves. Now contrast that ambition with how we used to treat. The old paradigm was a sequential monotherapy. Start one drug, watch and wait, and only add a second drug when the patient clinically worsened. The flaw here is heartbreaking in retrospect. By the time a patient had visibly worsened, they'd often already sustained irreversible RV damage. We were treating combination therapy like a rescue, something you reach for once things are falling apart, instead of a strategy you commit to up front. The data dismantled that old paradigm trial by trial. Serafin in 2013 and Griffin in 2015 proved that you gain by adding a second or third agent onto background therapy. But the real game changer was Ambition 2015. Ambition tested upfront dual therapy, ambrisentan plus tadalafil, started together from day one against monotherapy. The result? Roughly a 50% reduction in the risk of clinical failure. Starting 2 pathways at once before the patient declared themselves cut bad outcomes in half. Then Triton in 2021 asked the logical next question. If 2 is good, is 3 up front better? And the answer was nuanced. Upfront triple therapy improved hemodynamics, but it did not show a significant clinical outcome benefit over dual. So the honest takeaway is this. Hitting 2 pathways early clearly helps. The evidence for hitting all 3 right out of the gate for everyone is much weaker. So here's how it all comes together into a modern algorithm. Upfront dual therapy is the floor. For most patients, you start 2 pathways simultaneously, and for low to intermediate risk patients, that's typically oral dual therapy, an ERA plus a PDE5 inhibitor. For high-risk patients, you escalate to upfront triple therapy that includes a parenteral prostacyclin from the start, and you evaluate them for a lung transplant in parallel. Then you follow them, and you reassess risk and you refine. This is where the 4-strata model sharpens the picture over on the right. If they are low risk, you maintain. If they slip to a low intermediate risk, you switch the PDE5 inhibitor to a soluble guanylate cyclase stimulator, basically riociguat, or you add an oral prostanoid. If they're intermediate high or high risk, you add a parenteral prostacyclin and revisit transplant. The point is that treatment is a loop, it's not a one-time decision. And the goal of that loop is non-negotiable. It is not mere stability. It is a low-risk status, getting into the green zone. This is where I'll get on my soapbox for a second because the enemy here is clinical inertia. If a patient is stable, but they're sitting in the yellow intermediate risk zone and you leave them there because they seem fine, you are failing the goal. Stable but yellow is not success. The mantra of this era, we don't just treat symptoms, we treat for the 5%. We chase the 1-year mortality as low as it will go. We try to get them to the green zone. To recap the polypharmacy era, upfront dual therapy is the standard. 2 pathways at once is the modern floor. upfront combination cuts the risk of clinical failure by about a half on the strength of the AMBITION trial. Triple therapy improves hemodynamics, but its role as a universal upfront strategy is still inconclusive, though it's essential for escalating our high-risk patients. Wait-and-see sequential monotherapy is obsolete because waiting for worsening means waiting for irreversible RV damage, and success is no longer defined by which drug you use. It's defined by the risk status you achieve. We had become very good at using our tools to relieve pressure and unload the ventricle, but notice what every single drug in the toolkit has in common. They all fundamentally vasodilate. None of them touched the thing Romberg saw in 1891, the remodeled sclerotic vessel wall itself, and that's the frontier of our final era. This brings us to where we live now, the molecular era, and the ambition here is fundamentally different from everything before it. Every therapy up to this point has at heart treated the symptom of the disease, the constriction. The molecular era goes after the cause, the remodeling. We're shifting from opening the pipes to reversing the disease, from dilating around the sclerosis to addressing the cellular signaling imbalance that created it in the first place, the very lesion that Romberg described in 1891. Remember I asked you to file something away, way back in the tablet era. Well, here it is. Let's go back to this picture. The deepest insight of modern PAH is that this is not, at its core, a problem of vasoconstriction. It is a problem of proliferation. The vessel wall is growing where it should not, and it comes down to a balance. On one side, pro-proliferative signaling through the activin pathway, and on the other side, anti-proliferative signaling through the BMPR2 pathway, the very gene we noted was mutated in heritable PAH. In disease, that scale tips towards growth. So the question that defines this era is beautifully simple. Can we restore the balance? The answer for the first time seems to be yes, and the drug is sotatercept. It is a first-in-class activin signaling inhibitor. Mechanically, it acts as a ligand trap. It rebalances the pro-proliferative signaling against the anti-proliferative BMPR2 signaling. It is, in the truest sense, disease-modifying. It aims to reverse the structural vascular remodeling that none of our vasodilators could ever reach. This is the first drug built to undo Romberg's sclerosis. The pivotal trial is Stellar, 2023, and the design itself tells you how far we've come. Sotatercept was added on top of stable background therapy, and most of these patients were already on dual or triple regimens, so the benefit is on top of everything else we already know how to do. The results were striking. A median improvement in 6-minute walk of about 41 meters over placebo, significant drop in PVR, and a drop in NT-proBNP, and on the morbidity and mortality endpoint, an 84% relative risk reduction in the risk of clinical worsening or death on a maximally treated population. On the safety side, it brings a genuinely new profile to watch, telangiectasias, a rise in hemoglobin and hematocrit, and thrombocytopenia. If Stellar asked whether it helps the broad population, Zenith asked the harder question, what about our sickest patients? Zenith specifically enrolled high-risk, functional class 4 patients, the most advanced disease, most of them already on triple therapy, including parenteral prostacyclins. And even there, sotatercept delivered. A significant reduction in PVR on the order of 30%, and, this is the part that gives me chills, measurable reverse remodeling, a reduction in right ventricular end diastolic area on echo. Patients held or improved their functional class despite their severe baseline. The message of Zenith is profound. The benefit isn't reserved for early mild disease. Even our most advanced, highest risk patients show real hemodynamic and structural improvement. Now a more sober note, because every new medication brings non-new responsibilities. As sotatercept moves into the real world, we're learning its safety signature. The most common issue is epistaxis, nosebleeds, approximately 1 in 5. More serious, if rare, are GI bleeds, which demand vigilance. We see telangiectasias, those small spider vein vessels. There can be fluid and structural shifts, new or worsening pericardial effusions in a subset of patients, and the need to monitor oxygenation for intrapulmonary shunting. And hematologically, the flip side of that hemoglobin rise can be severe erythrocytosis, alongside the potential for thrombocytopenia. The clinical takeaway is honest and important. As we finally start clearing the wreckage of this disease, we are introducing new biological signatures that require a different kind of monitoring than the vasodilators we're used to for 30 years. New power, new vigilance. So, the molecular era in 4 points. First, we've moved beyond the plumbing. We're no longer just opening pipes. We are targeting the cellular remodeling of the vessel itself. Second, the mechanism is genuinely new, targeting activin signaling, rebalancing the pro-proliferative and anti-proliferative signals. Third, the efficacy is real, and it is additive, with meaningful gains even on top of maximal triple therapy, and the first real evidence of reverse remodeling of the RV from Zenith. And fourth, with a new mechanism comes a new adverse event profile and new monitoring strategy that we're all still learning. So let me bring this tour home. I'd argue we are not only clinicians caring for these patients, but we are historians. We've inherited 135 years of stubborn curiosity running in an unbroken line from a wooden stethoscope and an autopsy table in Leipzig, all the way to the molecular signaling inhibitors we're prescribing in 2026. And here's the thing about these eras, and the reason the metaphor works. They are cumulative. We didn't abandon the ice pack era when the tablets came, and we didn't abandon the tablets when the molecules arrived. We layered them into a sophisticated, multi-pathway, risk-guided strategy that draws on every era at once. Epoprostenol is still the first and main drug that ever proved a mortality benefit. It's still in the cabinet. But I want to be honest about the unfinished business too. Even now, as we are finally clearing the wreckage of remodeling disease for the first time, our tour isn't over. It won't be over until we are making the diagnosis before the damage begins. That 2-year diagnostic delay from the NIH registry, we still haven't fixed it. Because the goal across all 7 eras, from Romberg to sotatercept, has never really changed. It's to make sure that every patient, whether they are in Leipzig, Bern, Switzerland, New York, or Indianapolis, where I work, gets the chance to live their life in the green zone.